Good evening. Welcome to the PWS USA webinar series. Tonight's topic is Advocating for the Person with PWS in the Emergency Room, presented by Dr. Dan Beaver. Before we dive into tonight's presentation, let's review some housekeeping notes. Please take a moment to write down the dial-in number and access code for tonight's presentation should you become disconnected from the call. The number is 914-614-3221, and the access code is 820-460-104. For those of you using the voice IP option, you may choose the option of dialing in at any time during the presentation. There is a question segment planned towards the end of the presentation. Please note that the dialog box located to the right of your screen has an option for you to ask questions throughout the presentation so nothing is forgotten. Your line is muted to alleviate distractions, so if you have any difficulties during the presentation or need assistance, please use the question box throughout and I will be happy to provide assistance as best I can. Please do not use the chat box, use the question box. If this dialog box is distracting to you, you can click the arrow to minimize it at the top, it's orange, and then click the same arrow to open the box back up and enter questions or comments. Allow me to introduce tonight's presenter. Dr. Dan Beaver is the adoptive father of a delightful 29-year-old young lady who happens to possess the gene mutation for Prader-Willi. He is also an emergency room physician who has navigated the medical establishment with his daughter as a parent while viewing it through the lens of a physician. Trained as a physician assistant working in Alaska in the early 80s, he then returned to medical school in Seattle, after which he completed residency in family practice in Marquette, Michigan. Changing focus to emergency medicine, he worked in emergency medicine in Ishpeming and Marquette, Michigan. Subsequently moving to Wisconsin in 1999, he completed emergency medical boards and has since worked in emergency medicine in Baraboo, Wisconsin, and most recently, Monroe, Wisconsin. I will now turn the presentation over to Dr. Beaver.
Well, good evening to you all. I'm hoping that we can explore some different issues surrounding emergency room. But first, a little bit about myself. As already noted, I have been in emergency medicine for going on 30 years. Hannah came to us as an adoptive child at 18 months. She's now 29. She does possess Prader-Willi. We have also been through the medical establishment with Hannah many times, both for routine health care and for surgery a couple of times. So we're aware both on a personal scale and from a professional point of view, the complications that you can run into when taking someone with Prader-Willi to the medical establishment, and tonight in particular to the emergency room. I'm going to try and zoom through this pretty quick so that there's ample time for questions. So please write your questions down, get them back to us, because I'm thinking that's where most of the real work is going to be tonight, is with your specifics. So let's just move on then. Okay, this is what I hope you basically come away with tonight. Things to remember. First of all, people with Prader-Willi are no different than anybody else. 911 is our friend. Anything that seems too dangerous to transport yourself to the hospital should warrant a 911 call. That's what they're there for. Now, when I say too dangerous, if the person with Prader-Willi is very ill, is in a great deal of pain, you might be the only person driving that individual to the hospital, which could be very dangerous if you're distracted from driving by whatever condition is that the person with you has. So ambulances in general can get to you quicker than you can get to a hospital. And you can also consider that ambulances have got a lot of the same things we have in the emergency room and can actually start treatment at your home. So never be bashful about dialing 911. Second of all, your hospital experience in the emergency room. This is a rather innocuous phrase, but the emergency room's job is to provide a screening medical exam to anybody who walks through the door. Now, a screening medical exam could be something as simple as walking in and out. It could be something as complex as multiple blood tests, multiple imaging studies, CT, MRI, things like that. So the screening medical exam is to make sure that when that ill person either leaves the emergency room or is admitted, that there's a pretty good idea about what's going on and that you have threatening issues. Now, from your point of view, let's talk about collaboration. These are the tools that I'll be mentioning over and over and over again. And one of the main things you can do as a caregiver or someone who's accompanying someone with Prader-Willi is try to collaborate, be part of the team. And the ways that you can do that are make the medical staff job easier. That makes you a valuable asset to them. And ways you can do that, try to take personal information with you, the personal doctor's name, the phone numbers, any specialists that are involved in the person's life, their phone numbers. If you have any data or information or paperwork, take that with you. Those are things that are going to make you a valuable asset and a member of the team rather than someone on the outside of the team that maybe not quite so valued. The other thing, if you'll remember, Up to Date. Now, Up to Date is a website that is available in every single emergency room I've ever worked in, but it is a website that deals with information about just about everything in medicine that is known to man. And theoretically, it deals in a way that is evidence-based. By evidence-based, I mean, let's not just talk about something because this is the way we've always done it. Let's talk about something because this is what tests, studies, specialists have all come to conclusions is the best way to do things. And on Up to Date, there's a very good synopsis of Prader-Willi syndrome with specific guidelines for clinicians about how to approach different problems in the person with Prader-Willi syndrome. Another way that you can be an asset, try to remember that PWS has a phone number. They also have a website, and on the website there's also a link to a great deal of medical information. Because if you'll remember, you may be dealing with a very busy emergency room where the clinician's attention is distracted in multiple different ways. They probably won't know much about Prader-Willi syndrome. So anything that you can do to direct them to quick information. Now, I will say, 20 years ago, I didn't know anything about Prader-Willi syndrome, and none of my colleagues did. Although I am seeing students and residents and fellows in the emergency room that I mentor, and they've all at least had a lecture on it. So we have come quite a long ways, but still, it's a long ways from a 20 or 30-minute lecture to actually dealing with a situation in the ER. The last issue, and the reason it's big and black and underlined, if you all have a copy of that medical alert book, I hope that you have it in a place where you can take it with you. If you have a smartphone, that's something that you can also take pictures of and put in a file folder under your photos, for example. You can have that with you. That also includes phone numbers, but that is also a very quick synopsis with medical alerts, things to be worried about in the person with Prader-Willi syndrome. So I can't recommend highly enough having access to that medical alert book. There's also a most recent edition which has an algorithm for abdominal pain, which we'll talk about later, because abdominal pain, as you all have probably figured out by now, is one of the most dangerous, lethal, and underappreciated issues that can lead to very, very severe conditions and even dying. Okay, another thing that you can do is negotiate. And so when you're with the staff, One thing that I think everybody needs to be very firm about is no one goes home with nausea, vomiting, or pain. As we all know, pain tolerance is very high in people with Prader-Willi syndrome, meaning they just don't feel pain. So if they're uncomfortable, something is really seriously wrong. People with Prader-Willi syndrome don't vomit, and they don't talk about being nauseous. If they do, that's potentially a very life-threatening situation. The next, be respectfully aggressive. We'll talk more about that, but there are ways to negotiate with medical staff, and there are ways to be respectfully aggressive without being confrontational, because it's the confrontation in a busy ER that sometimes people just dig in their heels and they're convinced that they know what's going on, and whereas you as the caretaker may see that, well, gosh, maybe we're missing something here. Part of that negotiation could also be considering a request for consultation with the next highest level of ER staff, or with a specialist, or if there's no specialty available, specialty access available in the ER, then suggest a phone call to the local regional medical center where they may have more specialty availability. And then the final step in negotiation, if you just don't feel that you're getting anywhere, you're really worried that things are really bad wrong and they're just not being appreciated, you can always request a transfer. But we'll talk a lot more about negotiation later. Okay, so what makes Prader-Willi syndrome challenging in the emergency room? Well, from a physician's standpoint who knows about Prader-Willi syndrome, again, we talked about increased pain tolerance, meaning people with Prader-Willi, they just do not feel pain. I mean, my daughter, I can remember hearing her in the next room hear a clunk on the floor and coming in and finding that she had lost her balance, fallen on the floor, and maybe bruised her forehead, or some serious or some sign of injury, but yet not a peep. And I'm guessing you all have appreciated that too. For a clinician in the ER not to realize that people with Prader-Willi syndrome have a different sensitivity to drugs than the average person. Sometimes they're overly sensitive and sometimes they're undersensitive, but the main danger is being overly sensitive to drugs. But especially in the setting of anesthesia, in the setting of pain medicine, in the setting of muscle relaxers, in the setting of medicine, that can be very dangerous for a clinician not to realize that starting at the lowest dose is the best way to go. Poor muscle tone is also a very big deal, especially if you're thinking about intubating someone with Prader-Willi syndrome. Respiratory vulnerability. Many of our people are overweight, so their lungs are already compressed from the overweightness of their bodies. But because of the muscle tone, for example, they're particularly susceptible to respiratory issues. Again, the lack of vomiting. If someone with Prader-Willi syndrome is vomiting, that is a huge deal. And that, again, should not be written off as, oh, they just have stomach flu, or whatever the issue may be. I'll just put in a little plug here. In the emergency room in general, the most likely things are the least dangerous. The least likely things are usually the most dangerous. So there's a continuum there. And depending on the clinician, if they're leaning more towards the least likely stuff, they're playing the odds in favor of the least likely, or most likely least dangerous issue, then those are odds that are not going to be favorable to the person with Prader-Willi syndrome. So we need to really be leaning more towards, unless you can prove what's going on, we need to worry that this is a least likely, most dangerous issue. Poor temperature response. Just because they don't have a fever doesn't mean that there's not something fairly serious wrong going on. whether it's a pneumonia or a bladder infection, ear infection, pharyngitis. And the last thing, and this is where you come in as collaborators. Uneducated staff are very dangerous for people with Prader-Willi syndrome. And as a parent, I can say that my most significant task is making people believers, because obesity, food seeking, things like that in this country are looked at, well, we all know, they're looked at as a emotional or a character flaw. Whereas in people with Prader-Willi syndrome, these are really quantifiable medical dangers. All right, moving to the next one. Now these are some slides that I've just tacked in here that I think underscore the things that we've talked about just before, but traits that can camouflage signs of serious illness. Again, fever, the lack of pain signal, the lack of vomiting, lack of loss of appetite, meaning that someone with Prader-Willi syndrome, they will eat and eat and eat and eat because that satiety signal, the signal that tells us we're full, they just do not possess. And then there's a picture of the medical alert book, which I seriously hope all of you have, or you can download somehow on a smartphone or device that you can take with you. That little book could be a lifesaver because it's concise, quick to read, quick to consult, and does give your concerns the legitimacy of something that. Okay, heightened awareness. Now, this slide talks about GI issues. And when we talk about GI issues from a ER doctor or a staff point of view, we kind of flip that around. If someone comes in nauseous, vomiting, complaining of abdominal pain, then that could be a huge number of things. That could be anything from bladder to gallbladder to gastroparesis to one of the more serious and dangerous things, which we call gastric wall necrosis, which means that the wall of the stomach gets so distended or pressured that it dies. And then you wind up with a hole in the gastric wall that then allows stomach contents out into the abdomen, which can be a killer. We'll talk more about that. So anything GI, I think this slide should underscore, could be a variety of things. Until you can prove what it's not, you have to consider that you're dealing with a life-threatening situation. And here we go, necrosis and or stomach perforation. So if you imagine that your stomach is basically a balloon with a hole in the top end that food comes into and a hole at the bottom end that food goes out of. Well, in people with Prader-Willi syndrome, many of us have what's called, I'm blanking on the word. Anyhow, food moves much more slowly through our guts, gastroparesis, than in the average person. So consequently, food can build up. As a result of binging, you can wind up with a huge amount of food in the abdomen. And if you can think of, again, the balloon filling up, filling up, filling up to the point that you wind up with a hole in the wall, and then what's in the balloon leaks out. And in the human body, where it leaks out to is into the abdomen, which is normally a sterile space. And so if that occurs, then you can wind up with bleeding, infection, and it can cause death. And actually, we've seen several deaths over the past years from this. Okay, choking is a really big deal. And that can be as a result of a skinny person eating a lot or an overweight person eating a lot. And I think you can see here from this slide of 163 deaths, and I don't know how long a period of time that was, but 11 choked on food from gorging. So what does that come out to, about 8 or 9%? So choking is a big deal. in my own personal experience with my daughter is before we knew that she suffered from Prader-Willi syndrome, one evening we were eating spaghetti and we were just amazed. She just kept eating and eating and eating. And then all of a sudden it was clear to us that her stomach was full. Spaghetti was coming up the esophagus and out the mouth. And we did a Heimlich and eventually cleared it all out. But I think we're all aware that people with Prader-Willi syndrome can eat to that point where there's just no more room for food. It comes right out. Okay, now again over here, the average age for choking deaths in people with Prader-Willi syndrome is 24 years. Now, in the general population, general public, we're talking about very early in life, 1 to 4 years. So again, this is something that you need to be aware of throughout the lifespan of a person with Prader-Willi syndrome. Now, here's the anesthesia part. And I again can speak with, from personal experience with this. And the anesthesiologists that I have met, or anesthetists, just real quick. Anesthesiologist is a medical doctor who has gone to medical school, then has specialized in anesthesia. Anesthetist is usually a nurse, RN, who has gone to advanced training that then has learned how to manage most anesthesia issues. They usually work under the umbrella of an anesthesiologist. Anyhow, most of these people that I have ever talked to, they are delighted to talk to anybody who has information about the risk factors of someone with Prader-Willi syndrome and anesthesia. And this comes back into the whole thing about how people with Prader-Willi syndrome respond differently to drugs as one part of this issue. So the rule of thumb is go low and then start out. So the average dose for the average person, which is usually based on weight, is something that most anesthesiologists have at their fingertips. And your advice needs to be to them, go lower, really low, because you will have someone under anesthesia for a regular person. They will not wake up for days. And we're actually finding that some of our people who go under anesthesia and are put too deep, they come out different somehow. And that's not been identified or looked into with any great depth. But we do have case reports of families saying, you know, since they woke up from anesthesia, they were really deep, they're not the same person. And I suspect that's going to be fertile ground for research in the future. Okay, the other issue is the high pain threshold. So that people who are going to be undergoing anesthesia, they need to worry about that. Sensitivity to drugs, temperature instability. Some anesthesia drugs cause change in our temperature response, so that will not be a reliable indicator. Thick saliva in the airway will also make intubation much more difficult. The obesity will also make intubation much more difficult. And we talk about apnea. Well, that can be from a variety of reasons. One is central, usually from the nerves. And then there's an obstructive apnea, meaning that you have lots of extra tissue in the back of the throat and in the mouth that can be kind of floppy and not allow air down. So again, a major thing for anesthesia personnel to be aware of. The fact that hypotonia, meaning not much muscle tone. So the fact that they're not going to have the average muscle tone that you might expect when you're intubating someone. That's a really big deal, because what we do is we blow up a balloon to try and prevent food contents, stomach contents from going where we don't want them. Well, without that muscle tone, you have to be very careful about that. Hypothyroidism is something we see in people with Prader-Willi, just like anybody else, but maybe in a little bit increased frequency. That's going to affect, again, drug response, temperature response, wakefulness, things like that. So there's a lot to be aware of in anesthesia episodes with our people. And I have found in general, if anybody's going to be sensitive to warnings about anesthesia, it's anesthesiologists. because anesthesiologists describe their jobs as 99% humdrum and 2% sheer terror. So when you tell them that this individual has a high potential for being in that 2% sheer terror range among the people they see, they generally take notice. So never be bashful about saying, look, if you think of anesthesia, I got to talk to that anesthesiologist. And again, there's a very good synopsis of anesthesia risk in the medical alert book. Okay, bone issues, fractures. People with Prader-Willi can walk on broken ankles. They just don't have the pain response. So one thing for physicians in the ER is if there's been a suggestion of an injury, x-rays are pretty much mandatory. If there's a swelling at a joint, but yet no pain when you're moving the joint around, or the fingers, or the long bones, x-rays are pretty much mandatory. And you can see here that fractures, you know, among young kids, about 3%. In the 6 to 18 range, you know, maybe 13% will experience a fracture. And this probably has something to do with as we grow older, we generally get more overweight, but more active. And in the 18-year and older range, the frequency even goes up. So if there's a history of an injury, of a deformity, of a swelling, anything, x-rays are really necessary. And speaking from a physician's point of view, if I see someone who seems competent and I'm moving things around and I don't see any deformity, then I may not do an x-ray, truth be told. But if someone comes into me and says, hey, look, they don't have pain response, there was an injury, I've seen my daughter or son walk around on a broken ankle in the past with no pain response, then that's where you're advocating, sharing, and becoming a member of the team. Scoliosis, kyphosis, osteoporosis, again common, which can lead to increased frequency of bone injury. The scoliosis and kyphosis, so those are conditions of the spine that are deformed. And there's many different flavors. But you can see here that by age range, there's quite a escalating percentage of people who are at risk for that. Hip dysplasia. Hip dysplasia basically is the ball at the end of the leg bone that fits into the socket in the pelvis, not meshing quite right. And that can result in necrosis, meaning that the ball of the bone dies. It can result in dislocations, a variety of things. So again, story of injury, story of fall, story of not walking quite right, even in the absence of pain, that really warrants imaging of one kind or another. So when we write down here, so where does the rubber meet the road? Well, you've got the people in the ER, you've got you as the caregiver advocating for the person with Prader-Willi syndrome, and then you as an advocate. And so we're just going to kind of go over this a little bit here. And I'm seeing here that we're about 30 minutes into our talk, so I'll try to wrap up in about 10 or 15 minutes so that we have a good 15 or 20 minutes to answer questions. Okay, so let's start with the ER. Oh, wait a minute. This is a slide I put in here for people in group homes, caretakers. What are some things that probably should be forefront in your mind? And those are, what are the signs of overeating and other danger signs that warrant an ER visit? Well, bottom line, people with Prader-Willi syndrome are no different than anybody else in many cases. So if there's something going on that would raise a red flag in your mind with your own family, definitely they go to the ER. And then again, all of the other things we've talked about, to lack of pain tolerance, or a lack of pain response, lack of temperature response, all of those things we talked about earlier, those are all things that should prompt you to think about seeking medical care, and if there's any sense that it's something that needs to be seen right now, then ER is the place to go. Okay, where's the medical alert book? Again, if you're in a group home, that probably ought to have a copy centrally located to go with the person and their chart to the ER. Ideally, you might even have one in each person's chart. And if you have some way to electronically take that with you, that would be great. Again, those phone numbers we talked about, very important. They make the clinician's job a lot easier, and that makes you an ally as opposed to a bystander. And then the website address to up to date again. And that's again just a way that, well, you know, I know something about Prader-Willi syndrome. This website will tell you a lot. It's very concise. So again, the medical alert book and the up to date are good sources of information for just about any clinician to get started on. Okay, so in the emergency room, the three things I'd like to focus on are the actual organization, what kind of philosophy you might run into in the ER among the staff, and what are some constraints that you might not necessarily be aware of, but if we can get those out on the table, then oftentimes it'll help get around certain roadblocks. Okay, let's talk about the staff. There's a lot of different people in an ER. In some ERs, they're all wearing color-coded clothing. They go by different names. When you come into the ER, you're probably going to be seen by registration people first. That may or may not be included with a clinically trained individual to triage to help decide, okay, so just how serious an issue is this? Can they wait in the waiting room for an hour, or do they need to go immediately back? This is one of the places where you, as an advocate, should start trying to raise a sense of urgency. And so when you come in and you say, well, I've got my son John, and he's vomiting. And you can see it in their eyes. Oh my goodness, this is the 40th person today who's been vomiting. And that's when you raise this sense of urgency and say, John never vomits. He has Prader-Willi syndrome. People with Prader-Willi syndrome never vomit. Those who do oftentimes are suffering from something life-threatening, such as perforation of the abdomen, gallbladder disease. Just start raising that sense of awareness right away. You may see techs of one kind or another. Those are people who are trained to do particular tasks. So if you can kind of start asking, okay, so what do you do here? That will help you target your advocacy. Among the clinical staff, so the people I just mentioned earlier, those are going to be more support staff. Among the clinical staff, you may see medical students, you may see family practice residents, emergency room residents, you may see people called fellows. It used to be that you can tell the difference by the length of their white coats. And that works sometimes. But, asking people, okay, what do you do around here? And if it turns out you're seeing a medical student and you think you're dealing with a really severe issue, that may be time to say, well, thank you very much, but I really think this is a pretty serious issue and we need to see someone with more experience. This is where you can start practicing that respectful attitude towards staff. Now, having said that, sometimes it's not a bad thing to see a medical student, because in a very busy ER, that may be your conduit directly to the top, where you can say something like, this is really a serious issue. Can you please go talk to your attending right away? All right. You will see nurses. Okay. Again, very talented generally, very educated, very experienced people. Again, who can be your conduit to the top of the food chain, so to speak. There's also a class of people called advanced practice. These could be nurse practitioners or physician assistants. Depending on their experience, they can be excellent advocates for you and the person that you're with. They're basically trained to manage mid-level to common issues. The more experienced ones can even manage much more complicated issues. But they're trained to take a very good history and physical exam, so information gathering. And there again, they can be a conduit right to the top. And there again, this is where you can start raising that sense of urgency. Next, you'll see staff physicians. Those are pretty much close to the top of the food chain in the emergency room, if not the top, depending on the size of the emergency room you're in. Above them and outside of the emergency room are potential people that will be a resource. Those can be consultants. Those can be a type of physician called a hospitalist. Nowadays, doctors don't generally admit patients and take care of them at the same time in the hospital. There are specialists who specialize in taking care of people in the hospital. And then there's always referral doctors, consultation with specialty doctors. So for example, GI or genitourinary if it's a urinary issue, or orthopedists if it's a bone issue. If the hospital you're in does not have immediate access to those kinds of specialists in that hospital, then you can also negotiate consultation with other referral centers. So that, for example, I work in Monroe, a town of about 10,000. We have a wide variety of specialists, but there are many kinds of specialists we don't have. So frequently during my shift at the emergency room, I will be talking with the specialists in Madison, which is the town of about 250,000, the state capital of Wisconsin, where there's the University Medical Center. And there is every flavor under the sun of specialists there. And I have yet to talk to a specialist at that level of training who does not have some experience with Prader-Willi syndrome. And the reason I'm saying all of this is that you may get a sense that the practitioner has decided that this is not a serious issue without the benefit of consulting someone who knows more about it. So there again, that's where you can gently negotiate with folks about that. Okay, so let's move on to the process. Again, we talked about registration, triage. That whole raft of clinical people is basically going to be gathering information. And they do that in a variety of ways. They either do it through a direct physical exam, through blood tests, urine tests, imaging of one kind or another. They may be trying different kinds of treatments while you're there, going through this whole process. At that point, then they come to some kind of conclusion, which we call a diagnosis. Based on the diagnosis, they will suggest, bear in mind, just because they're telling you what they think you ought to do doesn't mean that you got to do it. So, but they will recommend treatment and then disposition. And here again, this is the decision that's made. Where is the best place for this individual to be until they get better? For very mild illnesses with people at home who seem concerned and able, maybe home is the best place. The other end of the spectrum would be to be admitted to the hospital. There's kind of a middle ground, however, called observation. And that is a class of admission where the physician is saying, I'm not really sure what's going on. I don't think they're safe at home, but I don't know which way this is going to go. So we're going to keep you in observation. In general, that doesn't mean that you get any less care than an admitted patient, but it means that you're in an area of the hospital where there's clinical staff to keep an eye on you and then deal with anything that rises up. And that does have certain ramifications as far as insurance goes, but that's not going to be something that we'll talk about now. Okay, so what's the philosophy in the emergency room? Well, again, we talked about what's this medical screening exam. Some emergency room docs are going to be on one end of the spectrum. They're going to do a very quick check. They will do probably a pretty thorough job, and they will decide this is not a life-threatening issue, so we're either going to observe you, we're going to send you to a specialist in the morning, we're going to send you home with treatment, and if you don't get better, come back. So the purpose of that medical screening exam can be fairly complex, but there again, that's where you as the advocate in certain situations need to respectfully negotiate and say that, you know, people with Prader-Willi, nobody with pain, unexplained pain, vomiting, nausea goes home until we have an explanation. And we're not just going to call it viral gastroenteritis or something like that. Okay, as far as the staff philosophy goes, we've already mentioned it once. On one end of the spectrum are going to be people who lean more towards least likely issues being most dangerous, and they're going to do everything in their power to make sure you're not dealing with one of those least likely, most dangerous issues. And there are people who may slide a little bit more towards the other end, who are playing the odds and thinking, well, I tell you what, this is probably flu, so not very dangerous, so you can go home. And there again, realizing that that's a kind of a continuum that you may see in personal philosophy of people in an emergency room, that where you can advocate and say, well, you know, I'm hearing you say that this is just flu. Well, we haven't proved that. And we haven't proved that it's not gallbladder, that it's not a perforated bowel wall, it's not a perforated stomach, many of these other things that we've talked about already. And I have yet to run into any emergency room staff that callously sends people home playing the odds too much towards that end. But if you sense that, then that's something to be aware of. Okay, some constraints that you might not be aware of that are kind of behind the scenes. And anytime you walk into a really busy emergency room, you're going to sense people running around all over the place. Things that are happening, however, behind the scenes, everybody in the emergency room business now is being timed. We're being timed until we first greet the patient. We're being timed until we arrive at a diagnosis. We're being timed until disposition is decided, whether to admit or observe or discharge. So those are those complaints there, or not complaints, but those constraints that may not be you may not be aware of, but they're in play there. Money is a big deal. More and more people in the emergency room and all branches of medicine are being urged and encouraged to practice more, what's a good way to put it, economical medicine. And truth be known, there are times for that, but with people with Prader-Willi syndrome who have any of these big red flags, that's not a time to worry about that. Consultation availability. Again, if you wind up with a clinician who comes to a conclusion that you're not comfortable with, then have you talked with a consultant? And if you haven't, here's the phone number of the consultants that our person has been dealing with. Here's the phone number of the medical center that they've been to before for their surgery. This is another place where you can be a team player and an advocate that makes the clinician's job easier. Bed availability sometimes is an issue, although I've never been in a situation where that has really changed the outcome much, because if bed availability is an issue, then the knee-jerk reaction of most clinicians that I know is, if we don't have a bed for you here, we'll find you one somewhere. Timing is something that you may sense in the emergency room. Shift change. Sometimes there's overlap hours where one shift comes on, another shift goes off, where things come to kind of a standstill. So that, for example, in my institution, when the hospitalists come on, there's maybe a 30, 45-minute gap where they're not available to take an admission. It doesn't mean that your ill person, is not going to be cared for. It just means that sometimes things slow down a little bit around those times. One final thing I'll say in terms of what's happening in the emergency room is, just because labs and imaging are normal doesn't mean that something's not wrong. So as an example, I will use here the person with Prader-Willi syndrome who's suffering from abdominal pain. You can say that the blood tests are all normal. Now, blood tests are the least probably sensitive test if they're negative. Blood tests for abdominal pain, if they're positive, you can believe them. If they suggest gallbladder or pancreas or infection, things like that, then that's really valuable. If they're normal, then that really doesn't help you much at all. If the clinician comes back and says, well, I've got a negative x-ray of the abdomen. Well, x-rays, unless they're positive, don't really help you much. If they show air in the abdomen, which tells you there's been a perforation, that helps. If it shows a wildly distended stomach, or if it shows signs of the bowel being blocked, that's really helpful. But a normal abdomen x-ray tells you nothing. And in someone with nausea, vomiting, and abdominal pain, that should prompt you to move on to the next test, which should be some form of CT scan or another. And there again, in the medical alert book, there's a nice little algorithm there, or a roadmap to how to deal with someone with abdominal pain. Okay, enough of that. Let's move on here. So here's what you can do as an advocate. Okay, first of all, you can start generating that sense of urgency at each place that you come in contact with somebody. So at the registration desk, at triage. The triage may be in two parts, one at the registration desk and another in the exam room. You can start generating that, continue to generate that sense of urgency when the first clinician comes in, whether it be a medical student, a mid-level or advanced practice such as a PA or a nurse practitioner, or the staff physician. You know, these are the times when you say we're dealing with a rare genetic disorder. We're dealing with an issue where pain is not sensed. We deal with people who die from gastric wall necrosis, all of those things that we talked about, along with the floppy muscles, the complications of obesity, such as diabetes, apnea, all of those things. So start generating that sense of urgency right from the beginning. Because if you walk in and say, well, Jane is vomiting, and that's all you say, then in most situations, that's going to kind of bump your urgency level down a little bit. Okay, the other thing you can do is collaborate. Make the doctor's job easier. I can't tell you how much that means to me as a doctor. When I walk in the room and you say, Jane has Prader-Willi syndrome, 20 years ago, my eyes would have glazed over a little bit and I'd have thought, oh, geez, where can I go find a book that has 4 paragraphs that tell me what I need to know? And you say, well, it's a rare genetic disorder. These are the danger signals. Here's a medical alert book that is brief, concise, and has some guidelines for you. Here is up to date. The website has a very nice, concise description of Prader-Willi. And then here's the national organization. And there's a medical overview there as well. All right, along with having those essential physician names and phone numbers with you. Because in general, if you have a phone number for someone who has dealt with your individual with Prader-Willi syndrome, they're going to know a lot more about it than the average clinician in the emergency room. And let me tell you, I, along with just about every other ER doctor I know, we're all knows more than we do. And if there's a phone number that gives me a pipeline right into them, man, I'm all over it. So collaborate. Make yourself a partner. Okay? You can always be respectfully aggressive. Start by determining what is the role of the person at the bedside. Now, there may be someone who is part of the information gathering system, whether they're x-ray techs, lab techs, the techs who do EKGs, things like that. And they can gather information. They're not supposed to tell you anything about what the information means, though, because they're just not trained for it. But then once you start getting up into the clinical staff, so, oh, you're a medical student. Oh, you're a physician assistant or a nurse practitioner. Oh, so you're a fellow. So that means you've had 2 or 3 years of experience in emergency room. Okay. And then again, these are all people who can be direct conduits to the next highest level of knowledge, whether that's the staff physician, whether that's a consultant, whatever. But you can be respectfully aggressive and without being confrontational, and you can say something like, just so I know what your role is here. If you come to an impasse, and it does happen from time to time, then there are several tools you can pull out of your toolkit. One, you can request consultation with the next higher level of a clinician. That might be a consultant. And if that person's not available, that might be a neighboring hospital that has consultants, or it may be a final result, might even be a hospital administrator. Most hospitals have an administrator available 24/7, and their job is basically dispute resolution. So that if you feel like things just aren't going the way they need to go, then you can always request an interview with a hospital administrator. And it doesn't need to be an angry confrontation. It can be something as simple as, you and I disagree here. I would like to talk to a hospital administrator, please. Another tool, so request for transfer to a higher level of care. And then that gets someone else in the mix as well. And again, myself and most of the docs I have ever worked with, a request for transfer to a higher level of care always results in some kind of action. Okay, oops, I guess I am done with my prepared comments. If any of you have any questions, I'd be happy to discuss them with you now.
Perfect. We have had some questions submitted, Dr. Beaver, so I will go through those. Before I begin, Carolyn Loker is also on the line, and I am unmuting your line, Carolyn, so that should you wish to respond to any of the questions, you will be able to do that as well. Okay, let me start at the top here. Can you speak to the issue of low sodium levels? What is the risk? Why is this more common in PWS? And what can be done to reduce the risk?
Well, low sodium is a kind of a complex chemical issue in the blood. All blood has a variety of things in it, sodium being one. And sodium is one of the chemicals that is vital for all kinds of things in the body, such as muscle contraction, nerve function, things like that. So imagine sodium that's too low and the effect that might have, say, on heart contractility or kidney function or things like that. It's a function of how much fluid you have in your body and how much sodium you have in your body. And so it gets to be kind of a complex issue. Mildly low sodium can be a result of over drinking liquid, for example, or not taking in enough sodium. So here's a good way to think about it. If you take 2 glasses of water, both of them the same, filled with water, you put half a teaspoon of salt in one, half a teaspoon or a full teaspoon in the other, and stir them up, then the one with half a teaspoon has less sodium per glass of water in it than the other. So even though the water is the same, the sodium concentration is different. The other way it can work is you can have the same amount of sodium in each glass, water in it. So it can be kind of a confusing thing. Why people with Prader-Willi syndrome might have that lower, I'm not familiar with why, although it could be genetic. It could be a function of diet and fluid intake. There are certain levels where we really get excited about it and want to get things back in balance. The 130, 128 range, we generally want to do something about it, but we're not worried that we're going to be dealing with anything too awful. You get down around the 120, 118 range, and then you're definitely dealing with issues that could result in brain swelling, for example. So it's kind of a complex question. If you see it, it's something that needs to be dealt with. What can you do to prevent it? Well, frequent, your usual medical exams. Stay on a healthy, balanced diet. Try not to well, that's a tricky question because people with Prader-Willi syndrome generally need liquid because they're generally low on liquid. So that may have something to do, but that generally results in a higher sodium value. So I think I'm just blathering here and mumbling more, but I think it's mostly an issue that if recognized, needs to be investigated and dealt with. Okay. Carolyn, do you have any insight into that?
We have had a few cases with Prader-Willi syndrome going in with low sodium levels.
Mm-hmm.
Fortunately, most of our people do not like just regular water, unflavored water, so that's kind of a good thing in our case. But then you've had the other cases where they will drink, and you have to actually limit their water intake.
Right, because then you wind up with diluting the sodium that they have. And I suppose you could get into a situation where if people were binging on potato chips and high salt foods and not balancing that out with enough liquid, you could wind up with low sodium as well. So I guess I'd stick with it then and just say if recognized, it needs to be investigated and dealt with. And I'm assuming that each person's yearly health screening and exam should involve a test that tells you about sodium.
Our next question, how soon should we move from an X-ray to an MRI? My daughter has had 2 hairline fractures that did not show up on X-ray, and she was not treated on a timely basis. Should we always ask for an MRI if X-rays show nothing?
Well, that's a very good question, and that depends a lot on as we said before, you're generating that sense of urgency. And this kind of underlines again the idea that just because the tests are normal doesn't mean there's not something wrong. And in the hairline fractures, that issue is one of sometimes the cracks go back so perfectly together that a plain X-ray doesn't tell you the whole story. Injury, people are walking on a swollen joint. You could, as a physician, you could approach that a couple of different ways. You could pretend it's broken, watch it at home for a day or two, re-X-ray it a couple of days later, and if that then shows the crack or within a week or two shows healing bone, then you can assume that there was a crack there. The other way is, depending on where the injury is, CT scan may be the next best way to go, because in general CT is much easier to get than MRI. And MRI, at least in my institution and every place I've worked, is generally pretty busy, overworked, overscheduled, and so getting an MRI is not the easiest thing in the world. CTs are generally a lot easier, and depending on where the injury is, CT might be the next best thing to do. And there again, that's where you advocate and negotiate, and coming from a background of personal experience where you can say, hey, George, 2 years ago and a year ago had stress fractures or hairline fractures that weren't recognized on plain films, and then we had to come back 3 weeks later and then find it on MRI, and you can say, and that was very disappointing because of the, potential permanent injury that might have caused. Then that might be the way to prompt the clinician and to say, oh, okay, well, let's just go and get a CT scan and see what we see. So that might be the next most available test in the emergency room. As far as getting an MRI, boy, I can tell you out of the 5 or 6 times a month I would need an MRI, I'm able to get it maybe once or twice immediately, and the other 3 or 4 times it takes a day or 2. So that's not that they're not reaching for the best appropriate test, it's just that they're reaching for a test that might not be that available. So think of CT and then advocate for your loved one by saying, look, we've had hairline fractures in the past, they weren't recognized, eventually found it on MRI, what do you think about whatever? You know, and then that might generate that sense of urgency and it makes you a team player, you know, trying to help the clinician come to the best diagnosis.
I'm going to read this one comment from a mom before I go to the next question because I think it could be very helpful, especially to the professional care providers as well as parents. She writes, "We have an accessory called Road ID that gives us a lot of peace of mind. It is a Velcro band that we attach to his shoe that has a small metal tag engraved with his name and his unique patient number. First responders can call an 800 number on the tag, give the operator Nick's patient number, and they will have any information available to them that we have provided on a website. We have a lot of PWS information, also diabetes type 2, and his tendency to not chew food and can choke. We were also able to load a picture of him, his doctor's information, all of our home and work phone numbers. I think this could be useful to some caregivers. The website is roadid.com. Very interesting.
That's road, what's the rest of it?
Road, R-O-A-D, and then ID.com.
Okay.
We will now go to our next question.
Well, I think that's an excellent idea. That's an excellent idea. And there again, that's where you are helping clinicians with information so that you're a team, part of the team, and you're making their job a lot easier. So I'm all for things like that, and I'm definitely going to look into that. Yes, so the question?
Yes, sir. We had an adult die in Utah from a choking death. She got into the garage where food was in the garbage. The family was told that the Heimlich would not have done any good. When should we do the Heimlich maneuver?
I would do the Heimlich maneuver anytime that you have a sense that there's a choking episode. Now, it may be in retrospect that the stomach perforated, the Heimlich might not have made any difference, but that's nothing you're going to know. So if you're talking about someone who is obviously choking, blue in the face, can't vocalize, they can't make voice noises, that kind of thing, then I would just follow the algorithm, the choking roadmap, and use those maneuvers to try and clear the airway. Because I mean, potentially that's going to kill them. And in retrospect, I'm guessing that it's not going to do any harm. But in retrospect, if they do find a condition where it wouldn't have made any difference, I can't think of any situation where I wouldn't try to clear a choking person's airway in the field, rather than asking myself, gosh, am I going to do harm? Is it really going to make any difference? Don't ask those questions. Deal with what you can see.
Next question. My son is an attention seeker. He spent 5 days in the hospital because he was pretending to have seizures. My question is, how common is it for a person with PWS to have pseudo symptoms?
Well, now you're dealing with behavior versus medical issues. From personal experience, not necessarily with my daughter, but with other people that I know with Prader-Willi syndrome, attention seeking may have more to do with being in a hospital setting where they have increased access to food, for example, where the limits are not quite as firm, where they have availability to walk into a neighbor's room or get food off of a roommate's tray, things like that. So it could be attention, it could be access to food. That's going to be a really, really tricky one. What's the frequency of pseudo seizures or true seizures? I don't know that, but in any individual's case, that's an issue that needs to be evaluated by a neurologist. Might involve EEG scans, might involve MRI scans, CT scans, blood tests, things like that. And then at the end of the day, if you do come up with a diagnosis of pseudo-seizure, then that will suggest to you and the clinician ways to deal with the situation. But then, here's also the other trigger with that, and that is that just because you have pseudo-seizures doesn't mean at some point that you don't sustain an infection or a head injury and then wind up with a real thing. So it's going to be a very tricky, ticklish balance between setting limits and coming to a diagnosis that gives you guide to what to do about it. What I could suggest, though, to you, if your loved one does wind up in the hospital, be very specific about access to food, access to calories, so that the, what am I trying to think of, the enticement to go to the hospital is not there. If they know that there's still going to be food restricted there, they're not going to have access to food or the other things that might want to take them to the hospital, then maybe that behavior will be less likely to appear. So, yeah, no, that's a very tricky question. And arriving at a specific diagnosis should go through a specialist, and then good behavior controls regardless of whatever environment they're in. Hope that helped.
I think this will be our last question based on the timing, and it's kind of a lengthy question, so it'll probably have a bit of a lengthy response. My son has had dozens of episodes of gastroparesis, which from here on I'll call GP. Many of the times an x-ray was done, it was mostly air in his stomach and fluid and gas in his intestines. Many of these times, over 40, he was hospitalized for this. Do you know why at times gas is the culprit for GP? Does mouth breathing cause extra air in the stomach causing GP? Secondly, many parents I've worked with have children that may be in the beginning stages of GP. Maybe they have severe constipation. These families are told to give Miralax and follow up with a GI. They don't take it seriously. How do we get doctors to take them more seriously?
Okay, well, the first question, gastroparesis is more an issue of the muscles in the bowel that move food and fluid and solids and gas along. So it's less an issue of gas in the abdomen, or excuse me, gas in the GI tract, and it's more an issue of how well do the muscles that line the bowel move things along. So think of the bowel like a big long tube, and the muscles in that tube milk things along, and they have to contract and contract and contract to milk things along, okay? Kind of like when you're milking a cow. So when that occurs, whatever gas or food or liquid that is in the bowel tends to move much slower. So if you have gastroparesis, that means that things are moving slower. So that means then that potentially more stuff is in any given part of the bowel. And if, let's say, if they were then to be on narcotics, for example, or any constipating causing medications, then that potentially could put pressure in there that could cause a rupture. So it's not really so much an issue of swallowing too much air. It's an issue of that air and food and liquid not moving along. Now, a plain X-ray can give you clues about gastroparesis. if things are moving too slowly. If they come to a point where they actually stop, then there are pretty classic patterns of air that we see on a plain X-ray that tell us that something's backing up or blocked or partially blocked. And the individual here may have been admitted, probably had a tube down their nose into their stomach to keep the stomach empty of fluid and juices. And in most cases, those kinds of things then correct themselves, although if too severe, then occasionally require surgery. So again, not an issue of the gas, and actually the gas oftentimes is helpful. It's really more an issue of muscle tone and whether the muscles are working to move things along. Okay, the second issue of gastroparesis and people in the early stages of gastroparesis, I guess I'm not quite clear what that means, but I suppose that early on things might start slowing down and then accelerate. The slowness may get worse over time. How to get people to take it seriously? Well, you do have several resources. You do have the medical alert book. You do have the websites that we talked about that document gastroparesis. And again, gastroparesis is kind of it's an invisible cause of things that can result in bad outcomes. So becoming a team, part of the team, turning people onto the different sources of information, talking to gastroenterologists about your particular individual's issues, and then using that as another lever to help people who may not be quite as up to date on gastroparesis. I mean, if the clinician you're seeing is a family practitioner, mid-level person, outpatient, urgent care, for example, if you have the phone number of the GI doctor who is on board with you as far as gastroparesis goes, then that makes you an ally to that clinician, and you can say, hey, look, here's a phone number. Give them a call. Here's a website. This documents people with Prader-Willi are more likely to have gastroparesis. So we talked a little bit about this whole process of raising a sense of urgency, becoming an ally, making that clinician's job easier by providing them with easy sources of information, easy sources of consultation, and then moving on from there. If you do wind up with a clinician who's not a believer, maybe it's time to get another clinician.
Carolyn, do you and
Julie, may I add a couple
I was going to ask if
words?
you had anything you wanted to share.
Yes. First of all, thank you, Dr. Beaver. In a perfect world, we would have Dr. Beavers all over the place and Dr. Lokers all over the place, but we don't. And people are by medical professionals. And I think as a parent, advocating for your child with Prader-Willi syndrome is probably one of the hardest things that you have to do, because you're telling that professional that has a degree. So the one thing that I can tell you, that there have been many families that contact us and they can't get anywhere with the professional when they're in the ER.
Mm-hmm.
And we are very happy to help you get through that. I've talked to many nurses. If the doctor won't speak to us at PWS USA, I will talk to the nurse. So we navigate that way. So feel free to call. Please do not put any of that on Facebook, but call our 800 number. The other thing I wanted to remind you all that we do have the iPhone app available too. So the medical alert booklet and the GI algorithm are on that. It's a mirror copy of our website. One other thing that we have had happen, I wanted to make sure everybody realizes this, that if your child loses their appetite, they don't want to eat, something is drastically wrong. That's when you take them to ER and have them checked out. We had a death recently, and it was gastroparesis, and he didn't want to eat, and then by the time they got him to ER, it was too late. So always remember that loss of appetite is a big red flag too. Thank you.
Well, I
That's
know
absolutely true.
several of the attendees have written already and made comments about what an excellent webinar this was, and appreciation of your time and of the great information that they've received tonight. So I know they all join with me in thanking you, Dr. Beaver and Carolyn Loker and Dr. Loker, for your helpful insight. This has been a very, very interesting evening. Everyone will receive a link to the recorded webinar, which will be available for viewing for 1 week. So that you can view it again and have a chance to take it all in, because it was a lot of information. So with that, we'll sign off with our thanks to Dr. Beaver and to the Lokers. Good night, everyone.
Okay, now, just real quick, Julie?
Yes.
Julie?
Yes, sir.
Just real quick, you know, after a webinar like this, you're right, it's a lot of information. If any of you all there have questions later, weeks, 2 weeks, a month from now, please don't hesitate to get back to me through PWUSA. I'd be happy to get back in touch with you.
That's very generous of you. Thank you. Good night.
Okay, thank you, Julie. Thank you, Carolyn. Good night.
You're welcome. Thank you.